and substance-using women. So I have a lot of experience dealing with women who are pregnant and have a variety of substance use disorders. So the goal of this webinar is to focus on perinatal cannabis, but to do it in an evidence-based and practice-informed review of the topic. So again, I hope this material is relevant to the clients that you're dealing with in your work as well. So I'm hoping to cover the prevalence and factors associated with cannabis use, to be followed by short and long-term effects of perinatal cannabis use on both mom and baby, to look at how we can identify cannabis use during pregnancy, and to review the management of perinatal cannabis use disorders. Before we start talking about prevalence, I want to make sure that we're all using the same terminology. I think it sometimes can get very confusing when people use words interchangeably. But just to really look at definitions, cannabis itself is a generic term that's used to indicate any of the psychoactive preparations of the cannabis plant. And when we look at the cannabis plant, we know that it contains more than 400 different compounds, including more than 100 cannabinoids. And the most important cannabinoids are the three that I'm going to be mentioning here. So the first one is called THC. I think most people are familiar with THC. It is the major psychoactive ingredient in the cannabis plant, and it's responsible for the development of addiction and maintaining that addiction. It gives you reward, chronic use as a result of having that reward, and therefore leads to physical dependence and also withdrawal when you stop. Cannabidiol, or CBD, is the non-psychoactive ingredient, and this has some medical properties, and sometimes when people are using, for example, medical marijuana, they'd be using a strain that has CBD predominantly. CBN, cannabinol, is actually the primary product of THC breaking down, and THC is more likely to break down while it's in storage or if it's exposed to light and air. CBN actually has less psychoactive effects than THC, which is the parent drug, and it's therefore less potent. Now, frequently, when people are using the word cannabis, they're also using the word marijuana, and they're sort of using them interchangeably. It's not quite the same thing, but I think frequently the most common form of using cannabis is marijuana. So the most common preparations are marijuana, hashish, and hashish oil. They all have different amounts of THC, and predominantly when we're talking to most clients, they refer to marijuana use, which is actually a preparation made from the dried flowering tops and leaves of the cannabis plant. Hashish and hashish oil are less frequently used, and when they are being used, they're sometimes used more frequently, for example, in ingested preparations. So how common is cannabis use? Let's start with general population rates, and then we'll look at pregnancy data. So probably not surprising, cannabis is the most commonly used illicit substance in Canada, and this is based on national population surveys. The first national survey that was conducted, called the CADM survey, was developed in 2008 and ran until 2012. And in the last year of that survey, they found that the prevalence of cannabis use in the previous year was 10%. So this is meaning that in the past year, when they did the survey, 10% of Canadian adults greater than age 15 were using cannabis. This survey was then replaced by the CTADS, and the CTAD survey found a similar rate of cannabis use, so really not a significant difference. And this is the last data we have from the national surveys dating back to 2013. When we look at Ontario specifically, we have data from what's called the CAMH Monitor report. And this is the longest ongoing survey of adults in Canada dating back from 1977. This survey involves telephone interviews of adults aged 18 and older. They have almost a 50% response rate, which is quite a representative sample of the population. And they present data looking at 2013 estimates of substance use, and they also look at trends over time in their analysis. So what they found is a few worrisome trends. So first of all, they found that the past year use of cannabis increased from approximately 9% in 1996 to approximately 14% in 2013. There was also a significant increase in this time period among women. So women doubled their cannabis use in that time period. Again, another worrisome trend. And secondarily, it was more common among young individuals, so between 18 to 29. So we're looking at women of childbearing age being a representative sample of cannabis users. Furthermore, they also found that the cannabis use problems was also becoming more prevalent. So there was a report of almost 7.5% of individuals using in 2013 who were starting to experience problems as a result of their cannabis use in comparison to approximately 5% in the year before. So quite a significant increase in problematic use. What about during pregnancy? Not surprisingly, we have limited Canada data. However, we have the Canadian Maternal Experiences Survey, which was conducted by the Public Health Agency of Canada. And they found that 25% of women aged 15 to 19 reported drug use in the 3 months prior to pregnancy. And thankfully, this proportion was reduced to 3% for the duration of the pregnancy. The most common drug in this category of listed drugs was actually marijuana, not surprisingly, or cannabis. Data from the National Survey on Drug Use and Health from the U.S. also has found some similar estimates, and they found that their prevalence of illicit drug use during pregnancy was anywhere from 2 to 5%, and also similarly, cannabis being the most frequently reported illicit drug use even during pregnancy. So this is data from the Canadian Maternal Experiences Survey, and it shows you that the use of street drugs was related to maternal age. So women who were aged 15 to 24 had the highest proportion of illicit drug use. So 25% again in the first 3 months before pregnancy, reduced to 3.4%. And when we look across the age groups, so the lowest proportion was actually among women between 30 and 34. So age is one of those determining factors in terms of screening for cannabis use to be considered. This is also further data from the National Drug Use and Health Survey from the U.S., and they analyzed their data from 2002 to 2014. This is based on self-report of marijuana use. They looked at the comparison of pregnant and non-pregnant women from 2002 to 2014. They looked at past month's use and past year use. They also were surprised by their findings. They found that the prevalence of past month marijuana use increased from 2.3% among pregnant women to 3.85%. So even if this doesn't sound like a high change in the percentage in terms of absolute numbers, it is worrisome because it represents a relative increase of 62% in that time period. So there is a trend of increased use and therefore more worry about the adverse consequences of the prenatal marijuana exposure. And similarly, past year use among pregnant individuals also increased from 8.6% to 11.6%. And obviously, not surprisingly, the trends we're seeing in pregnant individuals is mirroring what's happening in the non-pregnant population or the general population. When we look at what factors are associated with cannabis use, as I mentioned, age is one determining factor. Marital status, so single women are more likely to use. They're also influenced by the use of the biological father of the baby. There's also a correlation with lower educational and income levels. We know women who had less than 10 years of schooling were more likely to actually use 2 or more substances. And so we know that this is 30% more likely among that population of women than those who actually completed high school. If it's an unplanned pregnancy, there would be a higher risk of exposure, and also in multiples. So individuals who are certainly falsely, I would say, reassured from a first pregnancy that they think that it's okay to continue using even in future pregnancies. Now, beyond marijuana use, we have to be very cognizant that when we are dealing with women who are pregnant and they're reporting cannabis use, it's usually not in isolation. They come with a variety of other disorders or conditions that we have to consider when we're looking at counseling and cannabis use. So there's frequently polysubstance use. So these women don't just use cannabis, but they will have a higher risk of also using alcohol and tobacco. So individuals who have a past year or lifetime cannabis use disorder have a more than 50% risk of having alcohol use disorders or tobacco use disorders. There's also an association that those women who are actually able to quit tobacco, for example, during pregnancy, are more likely to also be able to quit alcohol and cannabis. So also has an effect in the positive way. We also have to consider their mental health conditions. So if they're using cannabis, is there a reason why they're associating their cannabis use with their mental health? So frequently there's a high rate of concurrent depression among these women, so 11% report depression, about 25% report anxiety disorder, and women have found that it may help with these conditions as well. And these women also come along with a whole bunch of other social stressors. So they're more likely to experience limited financial resources, family stressors, housing issues, poor nutrition. So therefore, when we're dealing with cannabis use during pregnancy, we have to address these factors as part of that general approach to managing cannabis use during pregnancy. And I would imagine if we don't deal with these factors, then we really aren't going to make a difference with our cannabis use. So let's look at the maternal effects first of cannabis-related disorders. We're going to look at cannabis-induced disorders and then cannabis-use disorders. So cannabis intoxication is actually a well-described condition by the DSM-5. DSM stands for Diagnostic Statistical Manual, so it's a very rigorous, standardized diagnostic tool developed by the American Psychiatric Association. They have criteria that need to be met in order for people to be identified as having cannabis intoxication. So these include having recent use of cannabis, followed by 2 or more of the following symptoms or signs within 2 hours of use. So conjunctival injection means red eyes, increased appetite, dry mouth, or a fast heart rate. They also have to have clinically significant problematic behavior or psychological changes as well. And if they're smoked, they will get this effect within minutes. However, if they're ingesting cannabis, they usually will get intoxication maybe 3 to 4 hours later. There's a lot of concern on ingested products because it's unpredictable when the release of cannabis will hit that individual. And it's also very worrisome if they're operating, for example, a motor vehicle because they don't know when they're going to get the maximum effect. So there is a little bit more unpredictability with oral ingested products because of that pharmacological properties. Frequently, they also have psychological and behavioral effects after the physical symptoms. They will begin with this feeling of high, but then this can be followed by inappropriate laughter, grandiosity, then maybe lethargy, some fatigue. They may also have impaired short-term memory and difficulty carrying out certain mental processes. There's also a component of distorted sensory perceptions where they will see the world in different ways. Colors may appear brighter, and they may hear sounds better. These sensory perceptions are very strongly associated with marijuana use. And if people experience these effects in a pleasurable way, this is what contributes then to their addiction risk. There's also other cannabis-induced disorders that are actually worrisome. So individuals who use more regularly are at higher risk of developing cannabis-induced psychotic disorder, anxiety disorders, and sleep disorders. This is from data based on large prospective studies that have found these associations with cannabis use. These conditions typically get more diagnosed when the symptoms that occur are much more severe than you would get with a high or with a regular use of cannabis. So it is very worrisome that cannabis increases the risk of psychosis 3 to 6-fold, and that cannabis can also promote the development of schizophrenia, and in those individuals with schizophrenia, it can lead to a poorer prognosis. So there is negative effects of using cannabis beyond the initial high. The other condition that frequently moms will report is cannabis withdrawal, and this is also a very well-defined disorder. They will present with 3 or more signs or symptoms of withdrawal within a week of quitting cannabis. This is primarily a psychological disorder, so cannabis withdrawal typically will present with feeling irritable, anxious, maybe depressed, having trouble sleeping, not eating as well. There is a requirement for 1 physical symptom, whether it's abdominal pain, sweating, tremors, or a headache. And we know that the severity of this withdrawal symptom will correlate with how much they were using to begin with and duration of their use. There is no antidote to treating cannabis withdrawal. It's mostly supportive counseling to get them through these symptoms. Symptoms typically will last up to 1 or 2 weeks, but for example, some of the psychological symptoms such as disturbed sleep may be ongoing for even more than a month. And this is very difficult to cope with if you're not sleeping for that time period. So withdrawal makes stopping from cannabis really difficult. They're more likely to relapse if their withdrawal symptoms are severe because of that worsening anxiety and sleep disorder. Now, because we know cannabis withdrawal is mostly a psychological syndrome, it's actually reassuring to pregnant women that they can actually quit cold turkey if they choose to do so. There's no risk to pregnancy. There's not going to be an increased risk of miscarriage or premature labor if they decide just to stop using cannabis altogether. However, they will require support for relapse prevention and to make sure that they're able to cope with the symptoms that they're experiencing when they decide to quit cannabis. Another condition of interest, and this is particularly in the perinatal populations because of the risk of nausea and vomiting of pregnancy, there's also a disorder that was first described in 2004 called the Cannabinoid hyperemesis syndrome. It's a very interesting disorder that's characterized by chronic cannabis use. So this is women who've been using more than 3 years, regularly, multiple times throughout the day, where they have episodes of hyperemesis, so frequent nausea and vomiting, and then they get relief with hot showers, and the pattern just continues on and on. So this prodrome where they feel unwell can be going on for even years or months before it goes on to the hyperemesis. But frequently it may come out more when they're pregnant. It is really hard, I think, to consider women, convince women rather, that cannabinoid hyperemesis syndrome is actually related to their cannabis use, because individuals who are using this much for this period of time have a harder time giving up their substance use. It's if we can convince them about how well they can feel by quitting cannabis, it's when maybe we'll make a gain. And typically in the recovery periods, when women are being treated for the hyperemesis, with hydration, with medications that resolve with the vomiting, if they're able to stop period of time and they can see how much better they feel, that's probably the most convincing evidence we have for women that this is a real condition. We know that with cannabis use disorders, continue to use beyond a time period, they can also have increases in dopamine levels. And this is what leads to development of physical dependence and tolerance. This is more likely to, again, occur in women who are using heavily or chronically. And what happens over time is that if they initially started using recreational because they felt well, after a certain period of time, they may notice that they lack control over their use. So they continue to smoke because they have no other avenue with relaxation. They crave to have a joint. They know this is the only way to feel better. So individuals who start using cannabis in their adolescent time period have a much higher risk of developing cannabis use disorder. And the percentage can be up to 10%. So that's concerning. 1 in 10 adolescents can develop a lifetime risk of cannabis use disorder. So a high proportion. And again, this then turns into adults who have a high risk of getting pregnant as well. So cannabis addiction is actually well defined. It is a real disorder, and again, the DSM-5 has criteria for the diagnosis of these women. The severity of the cannabis use disorder is based on how many criteria they meet. And we know again that women with cannabis use disorder, particularly moderate to severe ones, will have a much harder time achieving abstinence during pregnancy, and this is the population of women that will need our help. So let's move on to what are the effects now on baby and the child in the short and the long term. So when we think of pregnancy, what happens also to fertility? There is an effect on fertility. Again, this is not a well-researched area. There's a few studies that have shown that cannabis can affect both ovarian function, leading to reduction in certain hormones in the brain and also sex steroid hormones. And as a result of these changes in hormone levels, women are less likely to have regular periods, and therefore women who are using rarely may also notice a change in menstrual cycles, and this may affect ability to conceive. There's also some evidence on the effects of fertility of men. So acute use can affect sperm quality and quantity, and individuals who use in the long term also will have their brain hormones affected and therefore can even lead to reduced testosterone production. So men can also report declines in sperm volume count and abnormal sperm motility, and it's not surprising that sometimes fertility factors can be associated with men and not just with women who are using ongoing marijuana. In the pregnancy itself, there's actually very conflicting reports about is there any true negative consequences to cannabis use. So the pregnancy parameters that have been addressed in the literature include the length of the pregnancy, so the length of gestation, the quality and duration of the labor, fetal growth and birth weight, and birth defects. And I will go through some of these separately. So first of all, what's the association with fetal growth? From all the studies out there, there's very conflicting results, meaning some studies found an effect, others did not. There's very weak evidence for the association between any maternal cannabis use and a reduction in birth weight, length, and head circumference. There is also some evidence for a dose-response relationship, so meaning that those individuals with heavier use are more likely to see the effects. So one example from one of the studies was that the head circumference on these babies was more significantly to be smaller in children of heavier users. So we see some of these associations being brought forward in the literature. What about birth defects or congenital anomalies? Well, we know that THC, so the active psychoactive ingredient, has been documented across the placenta to the fetus, but there has been really a specific pattern of major physical abnormalities or birth defects identified with cannabis use. However, there's been some studies that have reported that in individuals who are smoking cannabis, or using cannabis rather, there's a higher diagnosis rate of an FASD type picture where these babies have more features consistent with fetal alcohol syndrome. And that's been seen specifically in women with heavy cannabis use. It's unknown if this means that these individuals are drinking heavily and also using heavily, and therefore the cannabis is more likely to make the effects happen with alcohol. So this needs to be further clarified. There's also individual studies, and again, these are older studies. So one of them in 2004 reported an increased risk of heart defect, so it's called VSD, or ventricular septal defect, in women who are using cannabis during pregnancy. This is based just on 2 studies, not high-quality studies, unfortunately. In one of the studies, too, there was some alcohol use. So again, it says more, again, the cannabis effect or the alcohol effect. In one paper dating back to 1987, they also found an association with an increased risk of strabismus or cross-eyed. In this study, they asked moms of kids who had cross-eyed diagnosed whether they're using specific substances in pregnancy. So women had to recall their exposures. So it could be that women either over-identified cannabis use because they had no other factors to associate with the outcome, or maybe it under-identified if women had to self-report cannabis use in the past. So again, I don't think we have any convincing evidence that there's a specific defect, but I think women should just know that there's these specific abnormalities identified in the literature, and obviously the less they use, the safer it is for their pregnancy outcome. When we look at breastfeeding, we are aware that THC has been documented in the breast milk of women who use marijuana during breastfeeding. Because cannabis and the breakdown products like THC are fat-soluble, this will obviously then mean that these products get into the breast milk and they will stay there and accumulate even up to 8-fold more in the breast milk than in comparison to the plasma or the blood levels. So therefore, one of the concerns is that for these individuals, if they're breastfeeding after smoking or using cannabis, they will have a higher concentration of these metabolites in their breast milk. We know that once the infants feed, they then will have more likely higher risk of having THC detected in their output. So there's been studies that have documented that they can detect THC in the poop, basically, what is fecal matter means. And this indicates that the babies are actually systemically absorbing marijuana and its metabolites. So what are the harms of this? Well, we don't really have, again, enough evidence. We know that breastfeeding exposes these infants during the development of their central nervous system. We have only 2 studies on neonatal growth and development related specifically to maternal use of marijuana while breastfeeding. Out of the 2 studies, one of them found an effect. They found they delayed mental and motor development at 1 year of age. However, in this population of women, even though it was a small sample size, they do wonder about how much of this was really an effect more of prenatal exposure and not just exposure while breastfeeding. So at this point in time, we don't have any conclusive evidence that breastfeeding on its own is harmful, but obviously we want to look at guiding these women appropriately. So my recommendations for these women would be is that cannabis is not contraindicated during breastfeeding. Cannabis is contraindicated during breastfeeding, so we don't want women to be using cannabis while breastfeeding because of the possible adverse effects on development. However, I wouldn't be against breastfeeding in someone who is using. And the reason for that is breastfeeding is not has so many benefits, and there's so much to gain for these infants, and also the benefit of attachment that I would be having a hard time saying, based on the evidence we have, that women should not be breastfeeding if they're using cannabis. The recommendations that can be also encouraged with these women is that we know there's a high concentration immediately after using. So for example, for women who do need to have the urge to, for example, smoke a joint, could they delay having that until after the breastfeeding has been completed so that the concentration, at least, of THC is less in the breast milk for the next feed. So again, to clarify, I would still encourage breastfeeding even in women who are reporting cannabis use because of the numerous benefits with breastfeeding. The other worrisome concerns are what are the long-term effects, obviously, of in utero exposure. We have some data to answer these questions from 3 long-term outcome studies that looked at the effects of cannabis use during pregnancy on child development and behavior. So the 3 studies which you may have heard about are the Ottawa Prenatal Prospective Study, or the OPPS, the Maternal Health Practices and Child Development Study, and the Generation R Study. So the Ottawa Prenatal Prospective Study was initiated in 1978 in Ottawa. It was developed to examine the effects of cannabis, alcohol, and cigarettes on pregnancy and neonatal outcomes. They started with 667 women that were interviewed during each trimester of pregnancy, and newborns then were assessed at birth, and then a smaller cohort of approximately 123 infants were selected to be followed long-term. These so-called infants have now been followed up to adolescence, and there's lots of data from this study looking at their outcomes. They also followed 50 non-cannabis users as well to have a comparison group. And in this study, the demographics included Caucasian women predominantly with a mean age of 29 years. Most of them had high school education and came from what was called middle-class families back in 1978. As I mentioned, these infants were followed late into adolescence, and the way they define cannabis use is by looking at the number of joints per week. The definition of heavy use in this study was 5 or more joints per week, so about 1 joint a day. The other study, called the Maternal Health Practices and Child Development Study, was initiated in Pittsburgh in 1982. They had slightly a different population of women they were following. They had mostly African American women who were younger, a mean age of 23, mostly unmarried, of low socioeconomic status, and most did not only had high school education. They also followed these women during pregnancy, and then a certain percentage were followed long-term. They actually had 829 women that were initially selected, and 760 of these infants were then followed ongoingly. They defined cannabis exposure a little bit different, looking at average daily joints instead of looking at the weekly amounts as in the OPPS study. And finally, the newest of the studies is the Generation R study, which was started in 2001 in Rotterdam, Netherlands. And this study is actually part of a very complex study that was developed to identify early environmental and genetic causes of normal and abnormal growth and development. So their population is also very different. They have a multi-ethnic cohort of higher socioeconomic status, mean age very similar to the OPPS study of 29.6 years, with 60% completing high school as well. So in some ways, some of the characteristics of the Generation R study is very similar to the OPPS mothers. The way they approached this study is they took mothers with a due date between April of 2002 until January of 2006 and offered them enrollment into this study. From this very big study, they had 459 mothers with cannabis use that they followed from prenatally to the goal is to follow them into early adulthood. At this point in time, they don't have data in the long term. Their data published is only up to 4 years of age. They looked at cannabis use in categories. So they looked at continued use during pregnancy, use until early pregnancy, use before pregnancy only, and then no use whatsoever. So they, again, categorized cannabis use in a yes-no fashion. So they didn't have a way of looking at dose-response effects. So based on these various descriptions of these long-term studies, you can see there's some limitations to their outcomes. So first of all the studies relied on maternal self-report of marijuana use. There was no standardization of dose or of use. They had concurrent substance use, so as in the OPPS study, some of the women also smoked cigarettes and drank alcohol. There were confounding factors, so they had to try and address issues of family history, of certain outcomes, environmental factors, maternal mental health, and socioeconomic status on growth and development, and obviously lots of subjects over time. So even though they started with a significant population at birth, not everyone remained in the study in the long term. So what were the outcomes? So this picture is reproduced with permission from the Canadian Centre on Substance Abuse. So I'm allowed to show this, but it cannot be distributed. Interestingly, there's a couple of, I think, important factors to look at this diagram. First of all, there is consistent areas of concern documented by both the OPPS and the MHPCD study. So both of them found concerning areas of concern as early as age 3 to 6, including deficits in cognitive function, behavioral, and academic problems. Some of the outcomes varied slightly between the two studies. However, these findings didn't just start, even though they started at 3 to 6, they persisted into adulthood. So when they reported their outcomes at 17 to 22 years, there were still ongoing concerns. The only study that found early effects was the Generation R study, and they found the increased risk of aggressive behavior, particularly among girls in their population of interest. So again, when we look at neurocognitive effects, so effects on brain development, we know there's a dose-response relationship. There's more likely to be effects among children with heavier users. As early as age 3 to 4, we can see changes in memory, verbal skills, verbal and visual reasoning. As they get older, there's poorer performance on tasks that require executive functioning. Executive functioning is the ability to really be organized and have higher level thinking. Some of these kids also have poorer reading, spelling, and academic achievement, but there was no impact on general intelligence, so the IQs weren't any different, but those high-level functions were being affected. Behaviorally, there was also lots of concerns identified. So as I mentioned, the Generation R study had an early finding, and then the other two also showed starting as early as age 6, so school-age children had more likelihood of having hyperactivity, impulsivity, and inattention. They also demonstrated higher rates of externalizing problems at age 10. There was also a higher risk of self-reported depression and anxiety as early as age 10. And by age 16 to 21, there was an increased risk of delinquency, increased risk of cigarette smoking, and cannabis use as well. So really what it's showing us from these three outcome studies that there is concerns in the long term for these individuals who are being exposed antenatally. There's also concerns in those who are exposed to more or heavier use. However, we don't have a quantity of effects, so we can't tell women that there's a 5-fold increased risk. We know there's just an association with these outcomes, and that the best way to reduce the risk of having these effects long term is to really look and address their cannabis use during pregnancy. Now, beyond the immediate postpartum period, we also know that there's an increased risk of disordered parenting. So there's problems with attachment in these individuals and also poor self-regulation. When we look at attachment, this is how the mom and the child relate. And not surprisingly, we know that in moms who have substance use disorders, there's a higher risk of having insecure attachment or disorganized attachment. Insecure attachment is because the parent is not responding to those children's cues, so the infants also then learn to avoid or ignore the parent. They show very little emotion when the caregiver comes or goes. Disorganized attachment is when the parents are reacting in very frightened or frightening ways when they're being stressed. So then the kids are learning that, you know, their parents are unpredictable, they're confusing, they're erratic, and they cannot be relied in. And this is concerning because we know with insecure attachment, with disorganized attachment, it leads to worse child outcomes. They also have trouble with their affective responses. They're more likely to have trouble in the long term as well, and they're at higher risk of developing substance use problems themselves, depression and anxiety as well. Self-regulation also relates to the ability to monitor, control behavior or emotions. So it's not surprising these moms may be using cannabis as a way of regulating their stressors. It's how they have adapted to stresses by learning to smoke cannabis. However, we know that with chronic use, it can lead to actually maladaptation. So the more stress they have, the more they have to use just to cope with circumstances. And this can also be harmful for parenting. So then overall, we know that substance-using moms and infants have lots of challenges when it comes to attachment to regulation. We have infants who are born more vulnerable and who require more sensitive caregiving. However, we have substance-using moms who may not be able to respond attentively to their children. They're less sensitive, less attuned to the infant cues, and it's not surprising that they have inappropriate responses to the child's needs. So therefore, these women then are less likely to form secure attachments to their own children since they're struggling with their own self-regulation. And again, the long-term risk is for both mom and the child to develop mental health disorders, and these kids may also be at higher risk, obviously, of ending up in out-of-home placements because of the kinds of environments they're being raised in. So this is another aspect to think about in cannabis-using moms, is again looking at that big picture going beyond the drug use, but what's really happening in the households. How do we identify cannabis use? We talked about the effects, but we first have to identify before we can even help moms. So we have lots of recommendations from national guidelines, such as the Society of Obstetricians and Gynecologists of Canada. We have recommendations from the World Health Organization endorsing that there should be routine screening identification of cannabis use during pregnancy. So the SOGC recommendation is that all pregnant women and women of childbearing age should be asked about their current and past use of alcohol, tobacco, and other drug use in pregnancy. And the WHO says in early pregnancy and every prenatal visit. But how can we ask the questions? And I think this is the difficulty. There isn't one optimal screening tool, and therefore we're more likely to end up with underreporting of cannabis use. A lot of these women are fearful of having child protection services involved, so they're more likely to say no the first time we're inquiring. However, one way to have positive results is by explaining why we're asking, reviewing the limits of confidentiality before we ask sensitive questions, and explaining to women that this is not a judgment on their parenting, however, it may be a way for us to help them cope better with life. And if there is a positive self-report, then we know that we need to inquire further into cannabis use disorders and then look at those other aspects such as polysubstance use and mental health disorders. And there's evidence that being asked about alcohol and other substances in a detailed manner may actually raise awareness among women about their substance use and may be more likely to actually modify this behavior. So screening, even if you don't identify, may raise that awareness for the mom. So it is a positive to be asking the questions. One suggested question for screening is a single question about past year substance use. So saying in the past year, how often have you used cannabis? This is a question in the positive. It assumes there's use because it's so prevalent, and it's easier for the mom to then say, no, I haven't smoked, or yes, I've had 1 joint or 2 joints. And as I mentioned, if there is a positive screen, then asking further questions. And for individuals who are not comfortable diagnosing cannabis use disorders, then there's the encouragement to actually refer on to other resources who can help make that diagnosis, or even help them with counseling around cannabis use and how can they abstain. Frequently, I think there's questions around how can drug toxicology be used. Now, we can test for the cannabis metabolite called THC because it is detected in the urine of moms. However, urine drug testing should never be done without maternal consent, and there's a window period of detection, meaning that unless you know when they last used, doing an individual urine drug test may not identify that specific substance. If they had a one-time use, we can maybe detect THC in anywhere from 3 to 10 days later. If they're using daily, you can find THC in their urine up to 4 weeks. So what that means is that someone who's quitting smoking, it may take a month for their urine to get clean. So there's evidence that there's a substantial agreement between maternal self-report and positive urine drug test. So the approach that's recommended by most, I would say, specialists in the field is that we use the screening questions first, and then we use the urine drug test as a confirmation approach. And this combined approach will detect 70% of cannabis use. As I said, there's limitation to drug testing in terms of window periods, but also one positive urine drug test does not make a diagnosis of addiction, so we have to keep that in mind as well. And definitely there should be no urine drug testing done without consent, and it should only be used as a confirmatory test once someone's reported their use. It should not be a way of catching someone at using cannabis, because most likely then that will lead to more an adversarial relationship between the provider and the patient, and therefore it's not going to lead to a positive outcome. So for women who suffer from moderate to severe cannabis use disorders, I think we need to use a more comprehensive approach to managing them. We have to engage them and retain them in care or in discussions. We have to offer integrated care. So for these women, they benefit from having both obstetrical and addiction services. They also need assistance with their complex psychosocial needs. And as I mentioned, parenting should be integrated with addiction treatment to facilitate bonding and attachment. This is actually a top-down approach to care. So the reason engagement is number one is that, as I said, if we cannot get these women to have discussions with us about their drug use, what's going on in their lives, then we're probably not going to really make a difference in the outcome of these pregnancies or in the long-term outcomes of these infants. Pregnancy is a window of opportunity, and we know that from numerous studies that have shown that pregnant women are more likely to access long-term substance abuse treatment programs, mostly because of a fear of child protection services, but also the fear of the outcome. They're afraid that they're causing harm to their pregnancies. And there's lots of evidence from, again, the U.S. when they looked at their trends in substance abuse treatment admissions from marijuana use, and they found that among pregnant women, there was a significant increase in the proportion of women that were reporting marijuana as a primary substance of abuse, and this increased from 8 to 20% over about a 10-year time period as well. So we know pregnant women will use the opportunity during pregnancy to make a change in their life, even if they were struggling before. So how can we gain this opportunity? Again, integrated care is key for these women. They need to have comprehensive care. They need to have preferably a one-stop shop model where they know they can get obstetrical care, addiction care, parenting skills. And we know from a meta-analysis which looked at programs that offered integrated care that these moms had improved maternal outcomes, so there were fewer drug use screening tests positive, they had more prenatal visits, they had fewer preterm births. The babies also did better. They had better birth parameters. There were fewer birth complications, and also led to less child welfare interventions or interactions. So this is one way we can overcome this. When we're dealing directly with the moms, one approach we can use is called brief interventions. So brief interventions are short counseling interactions. It's a treatment method that involves motivational techniques to assist these women with problematic substance use, and it's to help them understand the risk of use, increase motivation to change their use, and to teach them behavioral change skills. Now, brief interventions require several visits before it makes a difference. So we know, again, from evidence that if they have more interventions, more brief interventions, then they're more likely to make a change. They're not linked to, whoops, sorry, my computer keeps going back and forth. Brief interventions also work better if they're not linked to readiness to change, meaning that you would want to target all individuals, not just the ones that are saying they're ready to make a change. So even in someone who's pre-contemplative, you can have that discussion recurrently until they're ready to move on to the contemplative action stage. It's based on a harm reduction approach, so you're establishing that clinician-client relationship, and you're emphasizing a reduction in use rather than absence, which is very typical with harm reduction approaches. So what is the evidence for this? There's actually strong evidence for the effectiveness of brief interventions in primary care settings for both alcohol and tobacco, and there's moderate evidence for the benefit of brief interventions in a general population for cannabis use. So we have 3 randomized controlled trials that have shown that brief intervention can reduce cannabis use and can reduce cannabis-related problems. So it is an effective method. However, not surprisingly, there's no studies involving pregnant populations specifically. However, I can't imagine why brief intervention should not work in pregnant patients, and therefore they should be offered to all pregnant substance-using women. And finally, I wanted to make a comment on child welfare and legislation because I think this is a big component of the work that we're doing. So based on the Child and Family Services Act, we're not legally obligated to report a baby until it's born. However, in our viewpoint, early reporting may allow for better risk assessment and discharge planning. And also, women should be aware at the current time that there is a legal obligation to report concerns about child safety to Child Protection Services. Now, I'm not sure really what the change in legislation is this really would change because when we're looking at women who have moderate to severe cannabis use disorders, there would be a concern around the effect of her substance use on her ability to parent. So even when it becomes a legal drug, safety may still be a concern. So disclosure of cannabis use by a pregnant woman or woman who's parenting at the present time does require referral to Child Protection Services, and this may still be the case in a year from now if we're dealing with women with moderate to severe cannabis use disorders. Our approach is to involve the patient in decision-making, so for her to help determine when that phone call is made, we encourage her to also be involved in making the phone call herself with support from a social worker, and to be part of the conversation by sitting in the room while the report is being made. Realistically, Child Protection Services will not be apprehending a parent who may be smoking 1 or 2 joints, however, would be concerned around someone who has difficulty parenting, who's not alert, who cannot be providing adequately for an infant. So this is where the concern comes in with a child welfare legislation. And again, it's not a statement on bad parenting, it's a statement of safety for that infant in the immediate period and in the long term. So what are the key messages? I think it's important to realize that research does suggest there's a cause for concern. There's a link between prenatal marijuana exposure and short-term and long-term implications for both the child and the adolescent. Pregnant women should be advised to quit cannabis use due to adverse consequences on development and behavior. If they're not able to abstain, then they should look at reducing cannabis use because there is a dose effect on the relationship between cannabis use and the outcomes. Abstinence should be also recommended while breastfeeding, but like I said, breastfeeding should not be contraindicated in the if someone's still using cannabis. And we know these children may require more close monitoring for growth and development. This doesn't necessarily mean that they need to be followed, for example, in a NICU follow-up clinic, but they need to be followed by practitioners who are aware of these exposure risks. And to optimize outcomes, we should offer comprehensive integrated care and obviously community support that includes parenting training. So looking again at that big picture. And I've put together a list of resources and websites that I think can be giving you some more relevant information. And I will stop here and take any questions that people have so that I can make sure I can address your concerns as well.
Hello, well, thank you, Dr. Ordean, for this amazing presentation. And there's one question here. Do you think that the increase in cannabis use is because there is a true increase in cannabis use, or do you think it's something to do with less stigma attached to cannabis use? And especially since there has been legislation of marijuana in certain states in the U.S. Therefore, is it really our concern?
So I think there has been a true increase in prevalence use. When we look, I didn't present all the data over time, but some of the studies that have tracked, like for example, the Ontario study that has tracked outcomes from 1977, they saw a dip in the prevalence of cannabis use in 2004, and then it's increased again. So there has been resurgence of cannabis. It might exactly be because of the fact that it's becoming maybe more socially acceptable for some reason, that there's been an increased uptake of marijuana use. But also the other concerning pattern we're seeing, and I didn't present this data either because of time, is we're seeing an increase among adolescents. And that's where a lot of the guidelines are looking at. So if you're looking at the guidelines that they're putting forth for the marijuana legislation, they chose actually a relatively young age where marijuana would be allowed legally. And I believe the new legislation chose age 18. Well, that's worrisome because we have long-term outcome studies that looked at adolescents using from a young age, and the brain still develops up to age 25. So I do think there's a true increased prevalence in marijuana use. I don't think this is just something that we're seeing in the present time.
Okay, somebody else is typing a question right now. I just saw there was a link passed on today that if we have some input, there was a link passed that we could follow up through. You have seen that, I assume? It says Ontario seeking public input on federal plan to legalize cannabis.
So I'm not seeing that question.
No, it's not a question. It's an email that came in today through our listserv from Ontario. So they are asking for feedback right now. So it should be interesting to see what the professionals and public can do to change the course of the decisions. What did you feel?
Well, I know that I've seen, for example, the Canadian Pediatric Society has written a rebuttal to the proposed legislation. The Canadian Pediatric Society has their own best practice recommendations. They are concerned around the risk of early or adolescent exposure to cannabis because of their effects on the brain development. So, for example, a society like that, which is representing pediatricians, has put forward a concern and I'm sure there's other people who are responding to the proposed legislation.
Okay, thank you. There is a question here. Sorry.
I was looking at the question on harm reduction guidelines for use.
Okay.
There was a proposed guideline put forth from CAMH, I believe, by I believe one of the authors was Benedict Fisher, looking at harm reduction with use. So I can provide that link to that guideline if somebody wants to review that specifically. I don't recall all the details of what their recommendations were, but there is a document that's been put together, so we can definitely forward that out to everyone.
Okay, thank you. If you send it to me, I'll forward it, okay?
Mm-hmm.
Perfect. And here, does the cannabis make a difference if it's smoked or eaten?
They both are harmful. It doesn't matter whether it's ingested or smoked. In the studies that I was discussing, they were all looking at smoked cannabis, and none of the studies looked at ingested cannabis. But we know that, again, you're still going to increase your THC concentration in the body, and you're still going to have those same negative effects.
Okay, and there's another question here. Do you think the neurocognitive and behavioral effect in children is due to the mother using marijuana during pregnancy or breastfeeding?
Well, I think from the little studies that I said that we have, we know for sure there's an effect with women using during pregnancy. What we don't have is there more harm because these women were breastfeeding? And again, the 3 long-term outcome studies did not find that breastfeeding added to these poorer outcomes. So there was not enough of a population to say that breastfeeding alone increased the risk of the outcomes that we're seeing at age 18 to 21, for example. So we know for sure effects of use during pregnancy, and there's potential for further harm with breastfeeding. However, I would not want to discourage breastfeeding because of the benefits that can be incurred.
Okay, thank you. So there's no further questions right now in the chat. So I would really like to thank you for presenting this webinar to us. And the link that you will send about harm reduction, I will forward it. And I can see here on the last slide you put in your email address, so people can ask questions further on to you. Is that right?
Absolutely.
Okay, that's perfect. Well, I really like to thank you, and you're doing this next presentation again in August, so thank you again.
My pleasure, and I'll forward those documents, and hopefully this will help individuals in their work with these clients.
Okay, thank you, Dr. Ordean.
Thank you. Bye-bye.
Okay, bye-bye.